that my conflict of interest, that I previously worked as a civil servant in the Department of Health. So obviously today we're looking at the so-called dental recovery plan, which when it was published in February 2024, under the previous government, set out some ambitious aims for additional 1.5 million treatments, equivalent to 2.5 million appointments. So are we on track to recover?
Well, I'll have a first go at that, and then others will want to join. But I mean, the very short version is no. Within the dental recovery plan, there were 4 components, of which I think one didn't start at all, which was on dental vans. Might want to come back to that, but it was one of the smaller ones. Of the other 3, there were 3 elements which were aiming to address recognised problems. So the problems were real. Everyone, I think, would accept that, including dentists and people who look at this field. The solutions were unsuccessful. So the 3 problems that people were trying to address was, firstly, that the dentist would say, and the Chief Dental Officer, I'm sure, could give you better information on this, that the first appointment for a new patient takes longer and, or at least should take longer and be more complex potentially than for repeat patients. And yet there was no incentive for people to take on new patients. So there was a patient premium that was for a simple event for £15 and £50 for something which required greater measures. So the aim of that was to address a problem which had been identified by dentists as one of the reasons people were not taking on new patients in the NHS. The second issue was that there are areas of the country, and we've heard absolutely rightly, some areas are even worse than others, but there is no area of the country that is good on this, where there are particular lack of dentists. And therefore there was a scheme which I'm going to loosely call the Golden Hello scheme, just because I think it makes it clear what it was, which was £20,000 premium given over 3 years to people to move to those areas. These were areas that had long periods of dentists being advertised but not being able to fill posts, and this was a way of trying to incentivise this. And the third one was that the minimum unit of dental activity, UDA, amount has now just separated a long way, and I think this is absolutely fundamental to why many of the problems exist, actually, from what a dentist would be able to make in the private sector, and it was to increase the minimum amount that would be actually paid in that to try and help remove this. It only applied to a relatively small number of practices, but it brought those ones up closer to, in a sense, the market median amount of money that people could make for voice. So the concept behind them all was theoretically entirely reasonable. And so of those, I would say one of them clearly failed, which was the new patient premium. Mm-hmm. And the reason we can say it failed was the expectation was that this would lead to an increase in people taking on new patients. Now, there was evidence of an increase in practice for a short period of time saying they would take on new patients, but if you look at the numbers, there is no evidence that there's any increase over what you'd expect over the following year. So I think we'd all accept that one did not work. On the Golden Hello, I think it started relatively late, and I think it's too early to say how effective that's going to be in the long term, but some people have come into areas that have been difficult to enter. So I think in that one I would give it a provisional let's see rather than an absolute fail. It had not achieved its goals by the time the NEO looked at it, but that was relatively early on, and these things take a period of time, so I wouldn't want to say anything. And on the UDA uplift, I think anybody who looks at the dental contract would agree that the gap between NHS UDAs and what someone would make in the private sector is part of the issue. So I think the logic behind that was a reasonable logic. But of course the most expensive of those was the one was the new patient premium. That was the one that was also expected to have the biggest impact, and I think you'd all accept that it did not. That's a statement of fact.
Thank you for explaining clearly and in lay terms the different elements of the plan, and I know that colleagues are going to come back to those. I suppose I was really thinking about the headline in terms of, are we not on track to deliver the 1.5 million? And if we're not, how many additional courses of treatment have been delivered under the plan? That may be a question for you, Amanda, or colleagues.
Yeah, I can, Ali, I'm sure can provide a bit more detail, but overall, as Sir Chris said, or Professor Whitty, sorry, I don't know I've forgotten which one we're going for today. But as my colleague said, we are clear that the new patient premium, which was the one that was designed to drive more activity, has not only not delivered that, but actually, as per the NAO's findings, we have actually seen fewer new patients this year. Overall, UDA activity is on track to be about 1% higher this year than last year. So that is in line with the sort of increases that we've seen over previous years. So that would not suggest that the impact of the measures has resulted in anything like the outcomes that were hoped for.
I'm trying to get a number in relation to the 1.5 million, I think is I haven't heard yet a sort of we've delivered X. Have we delivered any additional appointments?
I don't think we have evidence that we've delivered additional appointments yet in year. What we've seen is that we've seen 2.7 roughly million new patients coming through already, but that is on track with what we would have expected to see if this year's performance had been similar to last year's. In terms of the impact of the Golden Hellos and the £28, we need to look at the year-end data this year to look at the contracts affected to see whether those contracts in particular have seen an increase in performance, which is a small part of the 1.5 million. But I think it's too early to say that at this point in time. So I think we can't say at this point that we've delivered towards the 1.5 million.
Okay, and so in terms of recovery, so in terms of relative to pre-pandemic, some of the data suggests that there's still some 4.7 million fewer treatments going on than there were pre-pandemic. So we're still way off recovery, not least recognising that even before the pandemic, dentistry was in a parlous state.
I think that's correct. So we have seen levels of access across adults and children increase since the pandemic, but they're not yet at levels that we saw prior to the pandemic. So, for example, for adults, we saw, as of 2024, about 40% of adults in the previous 24 months. If you compare that to before the pandemic, it was more like 48, 49%. For children, 56% in the 12 months, because we measure it on a different time scale. Before the pandemic, that was 59%. So the access for children has recovered at a slightly quicker rate because we try to prioritise that. But it's absolutely true that the access overall has not recovered to those levels.
Yeah. Okay. And I suppose the other measure of this is the extent to which, I mean, as we said, pre-pandemic, only half of people are accessing anyway. So we may come on to some of the more fundamental issues and how they're going to be resolved with dentistry in general. But obviously we're also seeing dentists still continuing to opt out of NHS, reducing the number of NHS hours, and some of them giving up on NHS practice altogether. So on that, any recovery, or is that still going sort of in the same trajectory that it was pre the recovery plan?
So we actually have a similar number of dentists doing NHS activity than we had before the pandemic. It dropped slightly in 21-22 and it's climbed back up again. But I think the fundamental point you're making is correct, that on average, dentists who work in the NHS are spending slightly less of their time on NHS activity now and slightly more doing private work. And some of that is for some of the fundamental reasons I'm sure we'll come on to, which is to do with the attractiveness and otherwise the performance of the underlying contract. But there are also broader workforce issues that are playing out in different parts of the country. There are other sort of conditions to do with the amount of money we have at the moment. You've already mentioned that we have obviously enough roughly to cover 50% of the population, but we also aren't making the best use of that money in the most flexible way to enable money to be moved from, for example, underperforming contractors to higher performing contractors. We've taken some steps on that, which I'm really happy to go into, but those are some of the fundamental reasons why we're seeing some of the trends you're describing.
I'll leave it for colleagues perhaps to follow up on that point, but thank you, Ali. I'll hand back to the Chair.
Yes. Can I